invitation. First of all, I would like to thank and congratulate and pay my sincere thanks and regards to this South Zone Tamil Nadu chapter and AOI conclave. The organizing committee, particularly Dr. Balakrishnan and his team. So thank you very much, sir, for inviting me to this August gathering. It's a brilliant conference going on since yesterday, and the campus is wonderful. I love this PhD campus. And being a Bengali from Calcutta, we are fish lovers. And yesterday night's dinner, I must say, it was a sumptuous dinner with plenty of different kind of fish dishes. I loved it. So after that, with this, let me start my presentation. Any science is ever changing and ever evolving, and the field of sleep medicine is even more. It is actually lots of grey areas are still there, and so what we deal, being ENT surgeons, we deal the subspectrum of sleep-related breathing disorder, SRBD, that is commonly known as obstructive sleep apnea. So continuously there is change and updation, recent development, and why it is? Because it is a global burden. It is actually a global burden, and if you see at this picture, all over the world, obstructive sleep apnea is coming like an epidemic, and just like India is a diabetic capital, maybe in next 5 or 10 years, India is going to be OSA capital as well, because currently we are the most populous country in the world, and all the populous country in the world, starting from our country, then China, then all this US, Brazil, is a huge health burden. And if we look at the statistics, how much the obstructive sleep apnea is a hidden health crisis. You can see the lost productivity, comorbid diseases, workplace accidents, and motor vehicle accidents commonly in the US. During 2015 data, it was not updated because of the COVID pandemic last 3 years. So during 2015 data was almost approximately $150 billion is actually the cost implication, economic burden because of this obstructive sleep apnea. So it needs attention. So what are the recent advances? I have basically designed my presentation as because my presentation is recent advances in sleep apnea. I have designed my presentation in the OA to what are the recent advances in sleep research, what are the recent advances in sleep diagnostics and therapeutics, and what is the future trend. Phenotyping is actually the current trend. During 1980s, 3 core principles actually described respiratory sleep medicine, and for last 3 or 4 decades, it dictated that the clinical pattern of male obese patients who snore and experience excessive daytime sleepiness. Number 2, the definition and grading of obstructive sleep apnea by the AHI, that is the hypopnea apnea index, and the predominant treatment only with PAP. This was actually ruling the field of our obstructive sleep apnea during last 3 decades plus, since 1980s, after the advent of CPAP machine by Collins Liman Group from Australia during 1981. But nowadays, OSA is considered as a heterogeneous disease determined by various symptoms and thermometric dispositions like skeletal issues, polysomnographic patterns, long-term outcomes, and comorbidities. And if you look at this picture, not only the apnea-hypopnea index by polysomnography, the outcome measures, how it is defined. Yesterday we had a wonderful panel on how to improve the outcome. It is not defined by PSG parameters anymore. The lifestyle parameters, the quality of life, snoring reduction, alertness level, and also the pathophysiologic phenotypes and the comorbidity issues are all taken into account, and this picture summarizes the OSA is a heterogeneous multidisciplinary facets of disease, and this is known as Eckhart model proposed by our dear colleague friend, international friend Dr. Danny Eckhart and Atul Malhotra. Their benchmark publication during 2013, PALM score, that is peak rate, arousal response, loop gain and muscle tone. This actually dictates why sleep apnea happens. And present and current knowledge and perspective on the treatment of OSA focuses on individualized treatment approach. It is not just common for all, that is not advocated anymore. 100 years earlier, sleep studies were initially recorded on analog polygraphs and they used lots of papers. For example, 2 sleep studies could use enough paper to require over a cubic foot of space, and such was the voluminous PSG machine. These are the original polysomnographs almost 100 years back, and these studies need to be recorded safe for 7 years because they were analog, and the polygraph themselves are huge, measured almost 5 to 6 feet, occupying the whole room, and not to say about paper cuts and ink stains. So there was need for development and advancement in the sleep diagnostics. Currently, there are miniature machines and even miniaturized. The type 1 lab-based polysomnographs are a bit voluminous, unlike, not definitely like those room occupying, but it is cumbersome. So, particularly after the post-COVID era, the social distancing norms and not to go away from the home and spend whole night in the sleep lab, there were advent of home sleep apnea test, and nowadays it is actually ruling our sleep diagnostic field across the world. There are 3 kinds of home sleep apnea tests, type 2, 3 and 4, beyond the scope of today's presentation, but most popular is type 3 sleep study. It includes minimum of 4 channels and at least 4 channels, preferably this kind of apnea link air kind of devices. Our technician go to patient's place, fit the instrument, just overnight kind of Holter monitor, overnight 8 hours, 7 hours sleep, and it doesn't restrict the patient from going to the restroom or movement. So nasal flow, respiratory effort, oxygen saturation, pulse and the snoring. These cardiorespiratory and snoring parameters we get from this kind of type 3 sleep study, and it gives a good data and information. And from our ENT perspective, this is actually an ENT forum, so we are not actually dealing with insomnia or parasomnia or circadian rhythm or movement related sleep disorders. So in our routine day to day, from practical point of view, our routine day to day sleep come ENT practice, type 1 from head to foot, 21 channel studies are actually not required, and these are actually our development, and industry and the science is progressing even more. Left side machine is the watchpad by Peterman. It utilizes peripheral arterial tonometry and actigraphy. It dictates about the position of the patient also, whether he is supine or lateral. And Aries by watermark utilizes forehead venous impedance and EEG leads. This is type 4 device, the newest in the industry. This is known as Night Owl one sleep test. The system consists of a small sensor device which is placed on the fingertip called Night Owl sensor, and a cloud-based analytic platform known as Night Owl software, developed by Ectosense from Belgium. And this is 8-SAT. This is actually also an 8-SAT, level 3 8-SAT, based on peripheral arterial tonometry, capable of multi-night testing. So it is even more advantage from those previous apnea air kind of type 3 device. We can do at least 3-4 nights and make an average of that to avoid the first night effect of polysomnography. And it is European CE and FDA approved and also validated. Now, what are the recent advances in sleep therapeutics? To cut the story short, we all know about importance of diet physical exercise and bariatric surgery, but the medical science, the physiology is actually coming up with some pharmacological solution.
For a history and a very excellent talk on this. And I have few questions, interesting questions to ask you. Can you please summarize the things to be done to reduce the obstructive sleep apnea for the freshers?
In one line.
One line.
In one line, how to reduce sleep apnea. So, toughest job, sir. Sir is laughing. So, really, in one line, I can say lifestyle modification is the key. So, OSA management starts with lifestyle modification. Maintain your weight, balanced diet, proper exercise. So, that is the first thing. Maintain your nasal patency level okay. That is management of allergic rhinitis. If any structural block, plan for surgery by consulting your ENT colleagues. And do proper guideline-based investigative procedure like sleep study. And if it is proven, and if it is not managed by lifestyle modification, then plan for some kind of, say, CPAP therapy or surgery.
Thank you, sir. Why I put this question to you is, I am recently singing nowadays, sir, but I have found I am snoring for the last few months. So, I want to know whether singing can reduce this kind of problems.
Wonderful. Brilliant question. So, singing reduces. Singing and all kind of flute instruments, be it trumpet or mouth organ, actually we ask our patients, they just go back, recapitulate, reactivate your college-like passions. Yes, once upon a time during my college days, I used to do a wonderful mouth organ. So do it, because it is nothing but that oromyofunctional therapy. Singing is a kind of oromyofunctional therapy, and blowing the pipes and the flute and any kind of musical flute-based where your neck muscles get activated, it actually helps.
Thank you so much. And another question, sir. I want to know about the recent Inspire device which plays a role in obstructive sleep apnea. Can you elaborate on this?
Inspire and Inthera, and nowadays Nixoa. There are three companies which have advocated. Inspire is the first during 2008 their benchmark STAR trial for hypoglossal nerve stimulation therapy, neurostimulation we call it. It's a kind of dynamic surgical management of the upper airway. The principle is to place some implant at the intercostal muscle level to get the apneic signals, and they place electrode around that branch of hypoglossal nerve which stimulates the genioglossus, that is the only protruder of tongue muscles. So the idea is, whenever there will be apnea during nighttime sleep, during sleep the body will get that signal from the instrument and it will stimulate the hypoglossal nerve, resulting in forward protrusion of the genioglossus muscle, resulting in non-collapse, that is there will be no more collapse of the tongue and improvement of the apnea. Patient instantly get benefit. So it is a continuous signal from chest and benefit over here. So this is known as hypoglossal nerve pacemaker, but this is actually contraindicated, I must say. This is actually contraindicated in complete concentric collapse at the level of phelum and oropharynx, and it is actually useless in cases of severe BMI more than 35 and AHI more than 65. So there is a stringent selection criteria, and in properly selected patient it helps. And in Stanford, their current proposition is, in most of our patients, yesterday during our panel also, in all my panelists basically made a consensus, in day-to-day, by DICE, by sleep endoscopy, we actually get most of the times, almost in 80% of our cases, complete concentric collapse. So hypoglossal nerve pacemaker will fail over there. So no role. But in Stanford, what they advocate, they convert this CCC just by doing mandibular advancement device. They are converting this complete concentric collapse into just simple AP collapse, and then do this hydroglossal nerve stimulation. So it is actually a dream in our settings where patient will do some kind of skeletal surgery first, then pacemaker later. So it has its stringent criteria. So not for all patients. And cost is very important issue.
Thank you, sir, for your informative time.
So first of all, I want to congratulate you on your presentation. So it was like a flow. You started from what was 100 years before and you reached the future trends. And I think most of the junior colleagues and PG students here would have been very much benefited from your presentation. So we know the struggle for sleep apnea to be recognized as a disease and ENT to be a part of the treatment team. I know how much struggle we had undergone because we were following it up right from our PG days. Now we know where we stand, and all because of the sleep surgeons who are behind us. I congratulate you on that work also. Sir, and the presentation was too good, sir. Very nice. Thank you, sir.
Thank you.
Thank you, sir.